well. So why the menopower summit, or why just looking at menopause in general? One of the main things that I wanted to do when we were looking at where is a significant need, area that's needed, but not really being discussed and talked about, and really, it's kind of one of those like little hidden little secrets, or kind of no one really talks about it. You just kind of suffer through. You may or may not have, an older woman in your life that had discussed any of those changes. Just kind of like, hey, we suffered through it. Oh yeah, by the way, that did happen. And kind of just hearing stories of, potential things that happened some time ago for them. So the menopower Facebook group and this summit was really meant for a safe space. So we're talking about a safe space for women to be able to say, hey, you're going through the same things I'm going through. We don't have to have any mystery or any let me say, not secrecy or shame, because this significant time is always, sometimes there's a significant shift in like our mindset and our bodies, and that even if individuals who didn't want, to have children, that as that feeling of something being taken away, or you're not able to have children anymore, or your value may be now changed in society without going through menopause, or like, oh, that's the end. Or we've been heard the terms like the change, it's over, hell, all the descriptions of this time all have negative connotations attached to it. There's no like series of hope that when people throw it, because I can probably ask, 5 different people, like when I say menopause, what do you think of? And it's definitely not coming out as a positive term. I rarely someone say, oh yes, it's a joyful time in life when women changes from one that, there's there, all the fluffy stuff is not there when you're talking about menopause. So I want to be able to take away the stigma and be able to say, let's have real talk here. Let's go ahead and move the needle when it comes to, menopause. So let's talk about a little bit of our topics, and presenters. So I'm going to be starting off with our topic number 1. Going to be basically talking about menopause 101, what changes are naturally occurring, what's, sometimes where the things that are normal and not normal, and kind of go through that timeline, and definitely have an option, for more question and answer for that. Then we'll have Cindy Bridges will be following us. These are kind of approximate times for us: 11:45 to 12:15. Dr. Sean Jones will be 12:15 to 12:45 for her top 5 nutrition trends. And then we have a little bit of change with our Q&A for skin and hair care. We do have the questions from our hair care specialist. She was unable to make it. So we're going to still have those questions answered there, as well as opening up to those that would like to add things. We'll have a quick little break after Sean. So that we'll have from 12:45 to 1, we'll have a quick little break set up for our yoga session. Then after that, we'll have our skincare and hair care. So our yoga sessions, we got a little remix in that as well. Had an emergency with the yoga instructor, but we have a special session that you'll have to wait until then to be able to see what we're going to do during that time period. And then I follow up with our last section on putting together what your menopause wellness plan looks like. So kind of taking things we learned today, how do we put that all together? A lot of times we go to things and they're like, oh yeah, I'm excited, I'm about to do this and that, and you don't have a roadmap for after that. The excitement wears off by the next day, and you're still falling back into maybe some common things just because you didn't have a roadmap or a guide for those. Now let's back up before we hop into that, and maybe never have seen me or met me before. I wonder if those are going to load up. Oh well, if they don't. Okay, so I have been a physical therapist for now. It's crazy now thinking about it. It's about 16 years now. So the journey has really started from always knowing I wanted to do something that was more impactful. And not just thinking about, hey, I can just look at and I can treat somebody's knee, you have knee pain, somebody's back, you have back pain, but really going into, there's a deeper there's deeper thing outside of someone's pain or injury. We really have to try to look at the total person. So through working with various different backgrounds and things, I saw that, guess what? I didn't really want to just see 3 and 4 people at the same time and bouncing back between individuals and really not giving quality care. And because that was not the reason I wanted to become a physical therapist. So that's when I decided to kind of branch out in 2017 in my own practice, and kind of been steadily building and really trying to figure out where can I make the biggest impact. And that really shifted through some of my life experiences with having issues with thyroid dysfunction, going through some, perimenopausal things, as well as thyroid into those late 30s and 40s, and really start honing on and saying, well, there's a real significant hole here. We don't have individuals that are out talking about these things outright to say what's normal, what's not, and then blending kind of pelvic health, physical therapy into the mix as well, looking at all things pee, poop, and sex, when it comes down to the general things when you're talking about pelvic health, and how some people are thinking some things are normal and they're actually not normal. So education, and then blending that, the perimenopause and menopause stage as well. Also active family here. Actually, this is a picture of my kids when they were younger. They probably, let me go back. They probably, like the one in the middle, he's taller than like the both of them right now. So that's an old picture. So our youngest one is the same height or taller than our older two, Sky and being the oldest, and then Eli, and then Donovan. So I always like that little picture. Now I bring it up to him when I see him. I should have posted the newest one when they're all standing looking at each other at the same eye level. Other photo, I'll have to pop those up during one of the breaks that are not showing up. So when it comes down to, there's 2 things that most women at some point are thinking about when you're talking about perimenopause, and some of y'all might catch some of this on the way out. People, cool and wet. Those 2 things work hand in hand. Most women, if you're having flashes and night sweats, you want to be cool. And the other part, the wet part, is the dryness and things that go on to whatever you want to call it, secret garden, kitty, precious, whatever the words that you want to call her. And there are 2 different words most women are gauging with. You want to be cool and wet at some point during this journey, or some point in your life. those two will run together. So let's talk about what is menopause. So when we kind of look back in some of the things, when we, I believe a lot of times we are readily able to talk about, hey, this new TV show, what's the new fashion? Let me do a review on this place to eat. But we are not really talking about what that family history looks like, or talking to some of our older women in our lives and looking at their experiences. And even with their experiences, every woman's experience with menopause is different. There's no cookie cutter or this and that. That's why you have some people that don't have very mild symptoms, and we have those that don't have mild symptoms, and it's really impactful for their quality of life. So another area is we don't talk about issues down there. So we don't really have open conversations about pelvic health, as well as looking at menopause change, which are very important. So we want to definitely be working on during this time period is, let's breaking the stigma around these discussions. And that's so that we are able to build that supportive environment for people to be able to seek help and advice, because we have the knowledge. Now we can understand where is it that we need assistance and help, and not just thinking, oh, it's just because of this. That's why I have this going on, and not really taking a step forward to say, hey, there actually is something that can be done, and I don't have to just suffer through it. So menopause. So when we're talking about menopause, one of the terms that we commonly hear is about the change, and they're like, what's the change? Everybody's like, what's the change? You just hear the word the change, and they're like, oh, it's just this and that. And of course, the negative things that are associated with it. So the actual term menopause, we're going to lose it at the general term that a lot of people use it as. So menopause is actually a point in time where you've had 12 months after your last cycle. So menopause is really, you've had January 1 through January 1 and you've had no cycle. That is menopause. At that day after that, you've had 1 year without, that literally is menopause. So in general terms, menopause is like 1 day, right? Anything after that full year, you're postmenopausal. So all the years leading up to menopause, you're perimenopausal. And that's when we get the onset of some of the symptoms and changes. And most people focus on, hot flashes and night sweats. And those are things that are very important and can be high in there. But we're not talking about, essentially, there's about 30 plus symptoms of perimenopause. So many women, and I can say it for myself too, sometimes you start noticing changes and things and you just push it off as, oh, it's because I'm tired. Oh, it's because I'm busy, work, school, kids, spouse. And you're not actually recognizing that, yeah, you're having some of this perimenopausal changes. I've worked with many ladies that all of a sudden that they're, could be 40, 45, or they could be 38 getting ready to approach into that 40. And I'll ask them about things like, and you say menopause, and they're like, oh, that's not me. That's going to happen in my 50s. That's way too far away from me. And you always associate it with, hey, it won't happen until this set time. And then as we talk and discuss even deeper, they're like, oh, I've been having these symptoms. I had like a night sweat in my late 30s, and I didn't really have anything after that, but I've been having brain fog, muscle joint aches and pains, insomnia. There's also increased anxiety and depression during this time. Mood swings. You're like on at one point and then off. Everybody get out my face at the next point. I know at one time I had it was some movie or show that normally, and I'm not normally like a crier person, and I was like watching a movie, and like all of a sudden I'm like crying at the end. I'm like, why am I crying at the end of this movie? I don't even normally cry on movies, but different shifts and changes that you just kind of shake off as, hey, it is what it is, type deal. And there's actually reasoning, and there's some things that we can do. Others talk about kind of the weight component. So we'll dig into deeper in some of those changes that occur. There's also, ladies will ask about after you've gone through menopause and the continuation of hot flashes. Yeah, there's an incidence that sometimes hot flashes can occur greater than 10 years after you've gone through menopause, unfortunately. And some of the menopausal and perimenopausal changes, they are intensified, or they sometimes a heavier effect in African-American women as well. So some of the symptoms are definitely can be more intense and last for longer as well. So typically that menopausal transition most often begins between 45 and 55. And like I said before, 7 to 10 to 14 years before, before the time period, you can begin to have some of those changes. But that duration can also depend on lifestyle factors. So such as smoking, age it begins, race and ethnicity, like we said before. So what's happening during menopause, during perimenopause, is the body's production of estrogen and progesterone, two other hormones that are made by the ovaries. They begin to vary greatly. So you kind of get swings up and down of those hormone levels that are going kind of haywire at some point, because our body is now going through that phase where we're not going to be producing, because after you don't have a cycle, then you're not going to be producing estrogen. So it's our body's change from not producing estrogen or not being in the childbearing years per se. And like I said before, African American women tend to have earlier, longer, and sometimes worse symptoms. But a key that we just said here is that, guess what? Some of those stuff is related to lifestyle factors. So it's not just, hey, it is what it is. It's just going to happen. There's nothing I can do about it. There's some things that we can do and adjust in our lifestyle. So some of the hormone changes. There's many women that are going through, we have natural menopause, and that's naturally due to age. And then we have surgical menopause. So sometimes even earlier, those that have had surgical menopause is basically menopause that can also be triggered by hysterectomy, removal of your ovaries, because those produce hormones. So any shift or change in what's going on with those hormones, that can shift you into much earlier having those perimenopause and menopause symptoms. And we see that a lot of times when these procedures are being done, and the follow-up over that, your primary care physician or surgeon is not telling you, hey, you're getting ready to jump psych right into to perimenopause, expect that you might start having some of these changes and really not having a roadmap or a game plan. It's just, oh, well, they took everything out or they did a partial hysterectomy and then no game plan after that. To be able to say kind of how can you optimize yourself after that. So when you do have removal of the uterus and ovaries, a lot of times those menopause symptoms, it's right away. You know, you start begin having those symptoms very shortly because now we've taken away those that hormone production. Let me pause here. Anyone that has any questions or comments they would like to say, you can throw those down into the chat. You can say, oh, wow, I didn't know that. Or ouch.
I have a question. So you mentioned that African American women suffer the most. Why do you think that is?
Well, you know, I think some of the things, I don't know if they've really honed into that, but if we look at numbers overall and we look at rates of obesity, heart
Mm-hmm.
disease,
Mm-hmm.
diabetes, we tend to have
Okay.
higher comorbidities already. So we're already
Mm,
at higher risk for some of those other things. And then we throw hormonal changes on top of that.
okay, yeah, that makes sense.
So we can see that sometimes those will be triggered. And as we know, now we're seeing, you know, a lot of those hormone disruptors are really becoming very common with some of the hair care products and perms and those like that. The chemicals inside of those, they have seen a link in those and kind of hormonal changes. So external things that are now changing what our hormone production is doing within our bodies. So, like I said, a lot of things environmentally are can have an effect. So it's not just, oh, I'm doomed to be able to gain weight just because I'm getting older, or I'm doomed to this and that. There's some things that we can definitely adjust as well. Okay, perfect. Thank you for that question. That was good. So leading right into that, why weight gain? So yes, weight gain tends to or can increase during this time. But like I said before, lifestyle factors play a role for sure. So we also, when you think about kind of going into your 40s and beyond, there's several different life cycle changes that could be occurring. Depending on what stage, if you had children or something, those children could be transitioning out of the house, or your little ones. You could have now parents that are older, and now you're becoming caregiver and having to assist with parents and loved ones, and tend to our activity level can tend to decline during that. So if you also have, now we're not taking care of our bodies as much, our activity levels are declining, that starts disrupting in how our weight gain. So we do have hormonal changes. Yes, there's a decline in estrogen levels. There's also age-related loss of muscle tissue, and lifestyle factors such as diet and lack of exercise. So when things that you can shift or change during this time, you can shift what your sleep, your movement, and then what's on your plate. Yes, what your nutrition when you're talking about weight gain. So it's not just, oh, all of a sudden I just start gaining all this weight during menopause. Yes, you could have, if you, another thing you can look at is family history for that. If you have, you know, family history that of other individuals that are also had, or their weight plays a factor in their health as well. But just because it's in your family doesn't mean you're doomed to have it. Because I've heard it so many times where, oh, my so-and-so's got diabetes, so I'm gonna probably go ahead and have it too. And that's not like it's been passed down. What's been passed down is the lifestyle factors. So it's not just inedible that you're gonna have this thing because a family member had it as well. You can be the one that kind of switch up and change that family tree when it comes to some things when going through the change. So we often see that weight gain often continues about a rate of 1.5 pounds each year as a woman goes through their 50s. So menopause weight gain can really have serious effects on your health, like we were just briefly talking about. Extra weight, especially around the midsection, it's going to increase your risk of many health conditions, breathing problems, heart disease, type 2 diabetes, as well as it raises your risk of some kind of cancers, including breast, colon, and endometrial cancers. So if you think about that shift in where you're carrying your weight, that midsection area, or what's just called visceral fat in that area, those are the high predictors across all, men and women. If you have a higher rate of visceral fat in those areas, those are going to increase your risk as well. And as we get older, our risk increases as well. Some of the main areas where individuals are getting diagnosed with type 2 diabetes, a lot of time it's into their late 30s and 40s. And they've probably been pre-diabetic for a while. I remember looking at a lady's blood work, and she's like, yeah, I get my blood work done every year. And she brought it in, or she said, oh yeah, my doctor said I was pre-diabetic. I had an A1C of, 5.8 or whatever it is. I'm like, okay, so what do they do about it? They're like, oh, they just told me I was pre-diabetic. And I was like, well, have you got tested again? Did you get a, roadmap for that? And they're like, no, not really. But she had been pre-diabetic for like 10 years. So think about if you're pre-diabetic and never got a plan and you only get your blood work tested once a year, how would you know if you're making any shift into full diabetes? And why aren't you getting a plan to shift yourself out of being pre-diabetic? It was just like, hey, they just kind of threw it out there as a thing. Or the other instance we see is that, well, they'll get right to medication. Won't even allow, lifestyle modifications or changes to occur. It's right on, hey, I'm taking metformin. Hey, I'm doing this, that, and the other, and they've been on it forever with no roadmap to get off of it. So really being aware of your blood work, and not just the once a year when your, company sponsors the health drive and you go down there and get your blood work and you get your, your testing out and the doctor says, oh, everything is within normal limits, but then you don't feel good. A lot of people are operating in the lower ends of those ranges, or sometimes the higher end, getting ready to tip over, and they've only gotten their blood work once a year. That's a whole full year now that you've lost to be able to make any changes and making sure that those numbers don't adjust or doing. So a lot of times when I'm looking at people's blood work that they get, I'm like, yep, you were at the lower end range of that. That could be potentially why you're feeling more like this, that, and the other. And I had that similar experience when I started having issues with my thyroid, and I knew it wasn't normal because I knew my body. So I went to, at that time, the primary care physician. Hey, there's got to be something, hormones going on. Let's test. Did the test, got the little thing back in the mail. Oh, all your numbers in normal range. And I'm like, I don't feel in normal range. So we got to dig a little bit deeper. So there's actually several layers of testing that you can do. It's the base level that your primary care physician will do it. And then it's the next level that digs deeper into specific, hormones that you can really see, especially if you're not feeling normal. You know how your body's operating. And if you don't feel normal, then you have to, I like to tell people, you have to be the CEO of your own health. If you're not the one in the forefront of it and you're like, oh, okay, it is what it is, I'll just take this, then you really do have to dig deeper, and you actually have to tell those providers the actual symptoms that you're having. All right, let's talk about nighttime torture. Insomnia. So insomnia, that a lot of times that comes with, also it comes with hot flashes and night sweats. So the nighttime ends up being quite a time for ladies in a certain age. You're not having difficulty with sleep. You're also having night sweats. Your temperature swings are going all over the place. And we can see some people that have, some women have more symptoms at night. That's their main complaints are going to be like the night sweats, and sometimes hot flashes as well. So things that we can do, and we'll talk about that more when we get into that last segment of the day. Some of the things we can do, we can look at some potential triggers. So before bedtime, what does your nighttime routine look like? Are you just hopping in bed and all of a sudden, or after you've been on your computer and doing and texting and looking at a gazillion TikToks, and you just hop in bed, it's time for bed? Or have you really set up what a nighttime routine looks like? So your nighttime routine could be, I need to downgrade some of the activities, which could be staring at screens, working in bed, guilty, sitting there with my computer, doing things, and then like, oh, time for bed. You never gave your body the signals that it was time to start slowing down and preparing for bed. So setting up and looking at what your nighttime routine looks like, as well as simple things as cooling the temperature in your room. adjusting what the clothing that you have on. That also, so you can have lighter materials, and then cooler, look at your bedding and make potential, if you have a ceiling fan, cooling things to be able to kind of prepare your body. Another trigger that's people are more sensitive than others is having that glass of wine right before bed. Caffeine and alcohol are also potential triggers that will affect our sleep. So it feels like, oh, that wine helps me go to sleep. Well, it may help you go to sleep, but you won't stay asleep. That's when you have the waking up. So some people are more sensitive when it comes to that. Then you'll have more of the I fell asleep, but then now I'm looking up at the sky at 2:30, 3 o'clock in the morning, and I'm also having a night sweat. And I had both of those scenarios. I remember the first time in night sweats, I'm like dripping, and my husband's arm is on me, and I'm like, oh my gosh, this feels like an oven. Please remove this arm from me because I am burning. He's like, you're sweating. Yes, I am. Please, I cannot be touched right now. I'm like, I gotta literally get like a towel. So we have to look at those potential triggers. That caffeine, that little alcohol. It's like maybe if you have that wine, like instead of having it at 9:30, 10 before bed, move that up to about 7 o'clock or so that it's not so close to that bedtime to have those swings, to see about if that's going to make an adjustment in those swings in temperature. Now, people do talk about some things with like natural supplements. We'll talk about that a little bit more into that later segment as well. Because once again, every woman's journey is different with the menopause. So someone else says, oh, I take this, or I took this herbal tea concoction, and that really helped me with my, night sweats. That's that, and that could very well that was indicated for you, but you do have to look at everyone as the individual and more customized planning for that. So quick things for that nighttime torture: adjusting temperatures, bedding your clothing, checking in to see, can I set up a bedtime routine that my body knows it's time to slow down. It's like, okay, I'm going to read lightly, I'm going to do a prayer meditation, and I'm going to shut it down or whatever. Get into some type of routine, and then being able to be more aware of also having a heavy fatty meal before bed too. So having a heavy meal, your body is going to be working to break down that meal more than, hey, we need to slow it on down to be able to prepare for bed. And I know that's a big thing with sleep. All right, bone and joint health. Good. Oh, my neck and my back and my neck and my knee and my I know if you drop down there in the comments if you've had a little joint pain in there, and you feel like it's like one thing after the other now. Like, man, I used to be able to just pop out of the bed and do this, or hey, I'm going to run down to the corner. No, there's not about to run anywhere real quick. You better get a warm up in, and you better be prepared for that movement, because that's what gets you in trouble. And everything, everything hurts. I say that. Yeah. And you have to think a little bit, we'll say smarter, not harder, during this. So on average, women lose up to 10% of their bone mass in their first 5 years after menopause. So leading up to that. So what does that mean? After this rate, the bone loss does slow, but about 1 in 2 women over the age of 60 will experience at least one fracture due to osteoporosis. So what does that mean? We're losing some of those joint protective measures with that estrogen. We're also, since we're losing some bone mass and bone density, the strength of those bones are also adjusting and changing, but there's things we can do about that. So what does that mean? We all know of the individual where they've had the fall. Or saying that they had a fall and then now they fractured a hip. Now they're doing, and we know after a fall and a hip fracture, that is one of the highest rates of premature death, as well as decreasing the independence. A lot of people at that point, once they have that fall and that fracture and they're older, that's that significant turning point where they're not living independently anymore. End up being able to look at assisted living, looking at certain areas there. So what can we do to help with that bone mass, bone density, and having the stronger bones so that we don't increase that fracture risk? And we know that it's going to speed up, menopause speeds up that bone loss. So prepping before then, there's things that we can do to kind of help bulletproof our body a little bit more, so that knowing this natural occurrences occurs, we can, have our bodies not more strong and more stable, so that it'll combat that natural process. So there are estrogen receptors in our joints. So that estrogen helps protect your bones, and it helps keep joint inflammation. So if you think about, oh, muscle aches, little this and that, estrogen once again is playing a role in that, in our inflammation marker. So that's another test. Sometimes I'll have individuals ask their doctor about getting, and then the doctor can interpret. So I'm not interpreting results. I'm just looking at results, because I'm not a physician. So if you think about inflammation is really one of the large indicators for a majority of chronic illness diseases right now. So we're talking about inflammation in our joints, we're talking about inflammation in our bodies. Now they are equating Alzheimer's, they're calling that type 3 diabetes. So inflammation is a component in heart disease, diabetes, cholesterol. So if you think about, oh, it's not just because so-and-so, had a history of Alzheimer's in their family, they're seeing a large component of inflammation being a high role in a lot of these chronic illnesses. And that's something that we can have an impact on. So estrogen levels, they're declining during perimenopause, which is, we're talking about kind of that first stage of menopause. And we can see we can get more joints can swell, become more painful. And then on my end in physical therapy, I'll see individuals just like, oh man, I'm having issues with my knees and my back, so I'm just not going to move at all. Well, the actual opposite is what we need to be doing. Movement is the first go-to line of medicine when you are actually having. So it seems like it's counterintuitive, like, oh, I'm in pain, so I shouldn't move. Well, the less movement we have, the more joint pain and stiffness you're going to have. Say, think about sitting in a chair for 2 hours. You go and get up, and it's like, let me get the engine started to start going again. When you incorporate that movement allows us to have more lubrication to the joints. So we want them to have, like I said, motion. Motion is lotion. If you want the joints to move better and do it, you have to give them some movement, and it's the right type of movement. It's not going from, hey, I haven't exercised in a while and now I'm in the gym doing boot camp 5,000, and killing yourself. And then now you're actually in pain because you didn't start at the right mode for you. You saw the newest fad, everybody's doing this new type exercise on TikTok, or you've saved like 55 Instagram reels on the new exercise you're going to do and get started. But yes, they serve a role, but was it set for the level that you were at right now? Probably not. You need, we want to take, like you said, take baby steps. The first thing is find something that you like to do and begin moving. Don't complicate it. It's had to be something, because I could come up with the best plan ever that's going to work for you. But if you don't have the time, it's not something you enjoy doing, it's not the perfect plan for you. So you have to look at what's working for you as well. Excuse me. So menopausal joint pain usually is worse in the morning when joints are stiff after you haven't been moving them at night, and tends to lighten up as the day progresses and movement increases. This is very similar to osteoarthritis, or what people just generally arthritis. Stiff and achy in the morning, you get movement, like you said, get some movement, and then things start to move up a little bit. And then the joints that are typically affected with some of the menopause-related pain is actually like neck. It's like a lot of upper. It's like neck, jaw, shoulders, wrists and elbows, which you would not typically think of. You think everybody thinks about, oh, hips and knees and back. That could also be some signs of arthritis in there as well, but some of the common areas for kind of menopause related joint, and that's, everybody's different. It could be joints throughout your whole body. Quick things to help. One of those, obviously, is exercise, it's quit smoking, and it's nutrition. So those are 3 things that you can do for bone and joint health. All right, we're going to grab into our last little segment. So what we want to do is a quick thing. I'm going to see if I can get this video going of intro to a little bit of the pelvic floor and how we can take care of our pelvic floor and look a little bit deeper into that. Let me see if I can get that to play.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis and stretch like a hammock from the pubic bone at the front to the tailbone at the back and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely. Notice as you tighten and lift your pelvic floor muscles, they tighten and close around the anal passage, vagina, and urethra. By exercising the pelvic floor regularly, you will train your muscles to work automatically when they are needed.
Okay, quick little overview. The only thing that I'm not, but then we'll talk about as well, that I do not agree with is stopping the flow of urine. We're going to talk about that a little bit deeper here in a minute, is on that you don't want to, you don't ever want to, when going to the bathroom, to get in the habit of stopping the flow of urine. That can actually lead to some unhealthy bladder habits as well, putting more stress on your pelvic floor, as well as sometimes increase of urinary tract infections. And it's going to sometimes incomplete bladder emptying when you're doing that. So if you're stopping it on, so that's the movement of kind of that pulling up and in. I always tell people it's almost like just thinking about like an elevator. So you're like pulling those muscles away and going up. So more, not like a clenching or tightening down. That's one of the main things that we start out first when I'm teaching ladies on how to do a Kegel appropriately. All right, so now we have a little question here, and I want you guys to respond in the comments there. So if I do Kegels, I won't have any leaking. So that means you won't have any accidents with going to the bathroom. True or false? Not have to listen to everybody's thinking like, wait a minute, maybe I should. We got one response in there. Let's see if we can get some more. Oh, we got a false. Okay, we'll take that. Yeah, so now I saw that video, everybody said false. So that is correct. A lot of people think that their pelvic floor is just weak, and that's why they're having issues with going to with not making it to the bathroom enough time, or when you cough, sneeze, jump, or do an activity and you leak a little bit. You actually could be having the opposite. So you could have a time where your pelvic floor muscles, as we saw in that video, all that red was pelvic floor muscles. So it's not just like one muscle working. You have like 13 or 14 muscles that are working to coordinate all those movements. So healthy pelvic floor also can make sure that you have good orgasms. Make sure you pee. Make sure you hold in your pee, hold in your poop, releases your pee, releases your poop, relaxes the muscle. The healthy pelvic floor is able to relax and contract when it's needed. So people think, oh yeah, they have the commercials, just do 1,000 Kegels a day, or I saw this one video and I'm just in the car, I'm doing my Kegels. Well, guess what? That was doing that and too many, and you could be causing more issues. So if you don't, you actually have overactive muscles and they're tight, and now you're trying to tighten them even more, then you're kind of adding fuel to what could be potentially going on. That's why it's important to get an assessment from a pelvic physical therapist. So that should be part of your plan, because that more tightening, if you're trying to diagnose and do more tightening, then you can make your condition worse. So there's multiple ways to be able to train your pelvic floor, just like if you're saying, hey, I want to have my, booty be bigger, my glutes is going to be that. Well, we know there's a bunch of exercises. I mean, squats and lunges and jumps and that. It's not just one particular thing that you can do for all those pelvic floor muscles to be able to coordinate and work the way that she did. So think about making sure that we get the accurate or right type of exercise before just throwing on a general exercise to a condition as well. So quickly, let's talk about normal and not normal. Think about some of these questions. Think in your mind, you might be able to answer them. How many times should I go to the bathroom per day? So this is one of the common things that I see pop up when women, they're finally saying, oh, I don't have any issues down there. And then they tell me that they're going to the bathroom like every hour, or they're going to the bathroom greater than 10 times a day, and they don't realize it. Naturally, how many times you should go to the bathroom? It's probably between 5 and 8. You should be able to hold your urine for at least 2 to 4 hours. That's normal. So if you find yourself going to the bathroom and just having the urge to go and just a little trickle this time, and then like 45 minutes early, you go back and it's a little trickle, or you go back and it's, you actually fully feel like you're emptying your bladder, there could be some mismatch on how those muscles are working and how we trained our bladder to be able to empty when it should be and how long. So it's a lot of ladies will end up with what's called just in case bathroom trips. I'm going to go to the bathroom just in case. I'm about to go to the grocery store. I'll go just in case. You really don't have the urge to go. You feel like, oh, I could go, but you've gotten the habit that every time you go somewhere, I'm just going to go just in case. It's kind of like when we did those car trips. We're at the gas station. Everybody go out there, just in case, because I don't want to be stopping, 2 miles down the road because y'all should have went to the bathroom. So it's even sometimes when we were younger, we kind of got in that mind about, let me go just in case. And we have some that have trained our bladder to go just in case, and it's not completely full. So it can lead to overactive things with your pelvic floor. Common things we're seeing with menopausal women. We have 1 in 3 women that experience vaginal dryness. So dryness due to estrogen fluctuations. And there's also tissue changes in our vagina and pelvic floor that occur that now can increase chances of having pain with intercourse during that perimenopause and menopause time frame. So those are all things that we look at in pelvic floor PT as well. Incontinence, like we said, it could be with urine, and it could be with bowel as well, and pelvic organ prolapse. So that's basically when one of your pelvic organs drops down from their position. So this could feel like a bulge or a pressure or like a falling out sensation in the vagina. That's due to the muscles and connective tissues in the pelvic floor losing some of that, and it drops down. So those are like 4 common things that can occur or changes that occur in the pelvic floor. And we can definitely talk a little bit more about that later. So wrapping up, this is, if you had a light bulb moment during any of this, go ahead and put light bulb in there, in the chat, put light bulb, anything that was like, oh, wow, I didn't know that. Oh, I might need to address that a little bit. Go ahead and drop light bulb in there. So a way that we grow and get the word out is reviews. So here's a link here. If you can scan that link and say, hey, give me a 5-star rating review on one of our Google pages. You can talk about what you didn't know before, what you know now, how any assistance that's been able to help you during this time. That really helps, because that's going to drive more women that need services as well. We're going to leave that QR code up there for a little bit. I'm also going to have Kayla drop that down into the chat.